thanks for the opportunity given. And recently I've shifted, for the past 2 years, I've shifted from a microkeratome to femtoflaps. So I had a lot of reservations whether I should, because I had fantastic and fabulous results, hardly any microkeratome complications. I can vouch for that. If you take care of the patient's eyes, you may not have it. So what was the reason I should shift it to femtoflaps? So now, after doing femtoflaps, what is my take on that? So this is what I'm going to talk to you about. So the comparison between newer microkeratomes and femtoflaps. We all know that LASIK is done in 2 steps, the creating the corneal flap and performing a laser vision correction. Methods of creating flap can be done with microkeratome or femtosecond laser, and now the newest all laser technique, the SMILE. This is a prototype microkeratome, this Amadeus 2, which I've been using for the past 10 years. And in this, the tissue is cut by a blade, and we determine the thickness by setting whether it's a 140 micron or 160 micron. The flap diameter depends upon the suction ring that you use, and the intraocular pressure increases approximately up to 65 millimeters and lasts for about 30 to 40 seconds. And I would tell you this is one of the best and the latest microkeratomes in which the suction is the minimum. The older generation microkeratomes would go as long as 1.5 minutes. So the limitation of microkeratome LASIK is that it's a meniscus flap. Does it make any difference? I'll talk to you about it later. Flap thickness is not predictable. That is probably the biggest bugbear, because particularly when you have a very high refractive error or a thin cornea, you're not able to regulate your correction based on what is going to be the flap thickness. So in these patients, probably an intraopachymetry would have to be done. And the flap diameter depends largely on the K. If you have a very flat cornea, you need to use a very large ring and to prevent any free cap or problems related to it. In case of steep corneas, the reverse holds true. Otherwise, you'll land up in a buttonhole. Patients with deep set eyes, it's sometimes very difficult to apply suction. So this is how a meniscus flaps looks when compared to a planar flap which is created by femtosecond laser. So these are the complications that you can face if you have not taken care of your the keratometry. So you can see this is something like a buttonhole, but fortunately only the epithelium has been involved. And probably in this situation, you can just remove the epithelium, go ahead with a PRK, but the surgeon has opted to do otherwise. He did a recut about 1 month later. This is again another patient who's got an inadequate flap. These are all problems related to the older generation microkeratomes. We don't get them anymore because we've understood microkeratome technology very well, and most of us are extremely careful about application of the microkeratome ring and choosing the right patient for the right ring. So all these problems can happen, and which has been shown to be to happen. And some studies say it can be as high as 1%, particularly in budding refractive surgeons. So the flap complications that you can come across are partial and incomplete flaps, free caps, buttonholes, suction loss, epithelial abrasion, different thickness, different curvatures, and of course a dry eye problem. This is again one of my cases which I had a free cap, which is very funny because the other eye had the same parameters and I used the same suction ring, and in spite of that the patient had landed up with a free cap. And fortunately for me, I recognized it as soon as I lifted the microkeratome. I realized there was no flap at all. So I looked for it in the microkeratome, found it on top on the microkeratome itself, desired to fold it so that we'll realize which is epithelial and the stromal side. Went ahead with my laser ablation and then put the flap back. So the advantage of folding is that otherwise you will not know which is the epithelial side and which is the stromal side, in spite of the marking. As you can see that I have marked this cornea, you can see it here. So that also helped me to put the flap back in the correct position. And all these years, 15 years I've been doing, I don't fail to mark the cornea. And it's definitely something very important take-home point I would suggest, particularly if you're just starting refractive surgery, because it will help you in some way. So the causes of flap problems can be many in microkeratome: loss of suction, electrical failure, it can be a blockage of the foot pedal. Just a Medosil sponge can block your foot pedal. I've seen this happen and surgeon keeps on pressing, it's not moving forward, the suction is on, it's cut halfway, finished. Then you look everywhere, then you find a small metal sponge which has got stuck in the foot switch. Accidental release of vacuum can happen if you're the assistant releases the vacuum. So all these things can cause a flap problem which probably is not remediable immediately. That is the biggest drawback with a microkeratome. Once you have an incomplete cut or a partial cut, then you just cannot proceed with the surgery. So, and other important thing is you have to be very careful about what type of ring you're choosing for the corresponding eye, because it's largely based on keratometry, and this can also happen. For example, if you accidentally choose a smaller ring, you can land up in a big problem, which is going to be a problem, your headache for quite a long time period. So that is the one important thing that I would like to tell. That is probably the biggest problem with microkeratome, that you have to be very careful about choosing the rings. Again, because the cut is more of an obtuse cut, it's not an acute angle cut. The chances of flap shifting very frequently. You have to warn the patient not to squeeze his eyes, not to squeeze his lids, not to touch the eyes, give protective cover in the night. Otherwise, they can land up with a flap striae, and flap striae leading to repositioning, epithelial ingrowth, and so on. And another important thing is that you can lift these flaps several years later. I've had patients coming after 3-4 years after a microkeratome flap with just a minor trivial injury and the flap has come off. So these are the downsides to microkeratome flaps. Whereas the femtosecond laser flap, as I showed you, has a planar shape. Does it have any implication? Yes, it does, because when you have a planar flap, it fits and you have a vertical cut, almost like an acute angle edge. So it sits in the bed just like a manhole cover. So it fits very well. The chances of the flap moving is much less when you compare it with a microkeratome. The other important thing is completely computer controlled. So if you want a desired thickness, the standard deviation is not more than 2 to 3 microns, whereas that cannot be said of the microkeratome flaps. So this is how the newer generation femtosecond lasers look. They are made of something like a polymer of plastic, and the beam control check is done for every cone that they use. It's a controlled suction. There are 2 suctions, one for the first suction, which is applied by the surgeon, and the second once the cone engages into the suction ring. So this is how the suction ring looks, and this is the eye, and following which the suction ring is, the vacuum is applied, and the suction ring, the cone is inserted into the suction ring. And once that happens, then automatically the second vacuum starts. Once the docking is over, and then the other advantages in these patients is, in particularly the newer femto lasers, is that the excess gas also gets released because of formation of a channel. So what are the patient and the physician benefits? The physician has got better control over the flap size, because you can make larger flaps, you can make thinner flaps, and you can center the flap even after the patient has docked. So that probably gives us the slightest, greatest advantage. And because of that, when you translate that, probably that gives the patient an additional advantage, that you can talk to the patient that there is definitely increased accuracy. In patients who have very flat corneas, or patients who have higher astigmatism correction, you can keep the hinge whichever side you want, so that you get a full ablation, which cannot be done with a microkeratome. And you can always ensure a very perfectly centered flap. So these are the different modalities. You can choose the flap size, you can choose the hinge, and it has got other features, such as you can use you can do it intacts, you can do keratoplasty. So there are additional features in using a femtosecond laser. The complications, like I told you, there have been studies which show that the incidence of complication is 1%. I do not agree with it, because I've been doing microkeratome LASIK for more than 15 years, and 1% is definitely an overstated figure. But nevertheless, you have to keep in mind that some of these very dreadful complications can happen with microkeratome. So the advanced laser technology of femto laser gives us the comfort that you can create the flap to the shape you want, the size you want, and it performs exactly as programmed. That is the greatest comfort to the surgeon as well as to the patient. The other advantages are the lower intraocular pressure, because some of the microkeratomes can go up to even 80 millimeters of mercury, whereas a femtosecond laser has a very much lower vacuum, say about 35 to 40, and the flap thickness accuracy is much more. An uniform flap thickness, like I told you, because of the vertical cleavage plane, it fits the bed like a manhole cover, so the flap slippage and wrinkling is much less. And suppose you do have a problem for some reason, the patient moves, I'll be showing a video on that. You can reapply as many times as you want, and you can complete the procedure even in the first sitting with very little adverse effects. In contrast, if you come across, like I showed you, an incomplete flap with a microkeratome cannot be done, probably you have to replace the flap and repeat the procedure or do a PRK after about 3 months. And it's because of the larger flap size, you can comfortably you can use it for hyperopes, larger pupils, moderate to higher astigmatism. Epithelial ingrowth is supposed to be much less with femtosecond lasers, because theoretically the epithelium has to grow into the crevice and come out. So it takes a longer time for it to migrate before which the flap sticks. So the epithelial ingrowth ratio is much less when compared to microkeratomes. These are some of the studies which have compared the advantages of microkeratome versus femtosecond laser. And here they have shown the flap thickness variability between MK flaps and FS200 flaps, that is a femtosecond laser flap, was statistically significant. What are the points against femtoflaps? Modern day microkeratomes perform extremely well, they are very safe, and the incidence of complications is almost nil, and they are much easier for the patient as well as the surgeon. The theatre turnout time is much faster. Flap edema is much more common in femtoflaps. There's increased incidence of DLK because of the gas bubbles which form. There is a condition called transient light sensitivity, in which the patient has sensitivity for no reason and has to be on long-term steroids for a long time. It's difficult to lift. Suppose you want to do a retreatment, it's going to be extremely difficult to lift these flaps because of stronger wound repair. And suppose you come across a situation in which the gas bubbles tend to accumulate, what is called as an opaque bubble layer, then you may have to postpone the surgery for a few hours before you start completing your surgery because of the difficulty in tracking. There is also a condition called rainbow glare, in which because of apoptosis of the femtoflaps, which can happen because of excessive energy, these patients complain of rainbow glare for quite a long time. This is one of my patients who had kept moving in spite of the suction, which can happen only in a femto. You don't see them very rarely you can see them in a microkeratome flap. If you watch carefully, you will see, I have applied the suction ring at least 4 or 5 times. As soon as I apply, he will move. See, he's moved. And this goes on, and at one point of time I thought, okay, Ben, this is going to be the last. I told him this is going to be the last, otherwise I'm just going to take you off the table. And then, fortunately for me, he did behave well. See, this is the 3rd time, and this is the 4th time. He has moved a little bit, not too much. So fortunately there was enough space. If you watch carefully, you can see an area of uncut tissue here. This is something like a vertical breakthrough, in which the gas has just come on top of the stroma. So it is just subepithelial. So, but fortunately, this area was a little bit away from the pupil. So I proceeded with lifting the flap and doing an ablation. The ablation was very minimal, say just only about 1 millimeter, and the patient did extremely well. So this is again what is something which you don't anticipate, because the patient moved, there was a minimal suction, and there was a slight vertical breakthrough. So it goes to say that femtosecond lasers do have their own problems, but probably they are more manageable. This is again a patient of mine who had an incomplete cut in the periphery. It was in the very early days when I just started, and I just could not understand what's going on. I kept trying to lift the flap and it's not happening. And because I did see the pediphyll cut very nicely, so then I decided to cut it open with a Vanna scissors, and after that everything went very well. I'm still not able to understand why the pediphyll cut was not complete. So clinical results have shown there is strong peripheral wound repair, more prominent peripheral wounds. They are slightly more difficult to open, and so this is the reason, probable reason, well, the biomechanical stability is maintained in these eyes, and they may resist ectasia. Less chance of flap problems with trauma and less epithelial ingrowth is again another advantage. They can be used for intacs. They can be used for intracord procedures, intrastromal procedures such as DSEC or penetrating keratoplasty. However, vision quality, because we are doing this is only a flap, vision quality showed no significant difference between a microkeratome versus femtoLASIK. And all complications with microkeratome can happen with femtoLASIK if you're not careful. Okay, I think these are some of the, again, studies which show that the difference between achieved and intended flap thickness, you can see it was only 6.7 in the femtolaser group, whereas it was 23.6 in the microkeratome group. That again is a disadvantage. Biomechanical response resulting refractive change was seen more in microkeratome flaps versus the femtolaser flaps. And statistically significant changes in induced higher order abrasions were seen after flap creation with a handcetome when compared to intralaser. So, in conclusion, femtolasers are a major advancement in LASIK. There is a higher degree of safety and precision with predictable outcomes and faster visual recovery, and increased patient satisfaction and comfort. And enhanced, I don't know, I cannot understand, this one may not, I may not agree on that because I don't find any difference between a microkeratome or my femto flaps. And it's approved by almost all major authorities. However, you have to understand the tools are only as good as a surgeon using them, and perfect results can be achieved by striving for perfection. So, having said this, I leave the floor with thought that microkeratomes are not bad, and if you don't have a femtolaser, don't worry about it, because for the past 15 years I've been doing only microkeratome. I've had fantastic results. All my patients can vouch for it. But femtolaser has given me an additional advantage and more comfort that whatever I plan is going to happen. So in that way, yes, femtolaser scores over microkeratome. Thank you.